Welcome to the COVID-19 webinar hosted at Vanderbilt University and presented by Chief Diversity Officers of the Southeastern Conference. I want to thank all of our panelists for being here today and thank all of you for joining us for this webinar. Today, there will be 4 panel discussions featuring medical and public health leaders, as well as government, community, and education leaders discussing COVID-19, health disparities, health inequities, and possible solutions. Each panel will start by being introduced by a Chief Diversity Officer. A moderator will then give brief remarks. After that, the panel discussion will begin. We appreciate those of you who shared pre-submitted questions, and we also encourage you to share questions during the panel discussion using the Q&A feature. We will do our best to get to as many questions as time allows. Again, thank you for joining us today. And now I turn it over to Dr. Andre Churchwell, Vice Chancellor for Equity, Diversity, and Inclusion, and Chief Diversity Officer at Vanderbilt University, who will introduce the first panel. Dr. Churchwell.
Thank you, Tara. My name is Andre Churchwell. I'm Chief Diversity Officer here at Vanderbilt University, as well as the Medical Center. I'm a card-carrying cardiologist, and a few weeks ago in a meeting with my SEC Chief Diversity Officer colleagues, we thought it was probably given time for us to weigh in on this, weigh in on the COVID-19 pandemic, given the widening spread of this condition throughout the southern states. We felt that if we pulled together our SEC best talent around this health issue, that we would have something to share and to share in this whole global dialogue of this pandemic. So you'll have a kind of an interesting cross-section of views from the different parts of the SEC and the different cities that they represent. My panel, which is a Vanderbilt panel and a panel that includes Nashville public health experts, consists of our moderator, Dr. Consuelo Wilkins, who's Vice President of Health Equity at Vanderbilt University Medical Center, Associate Dean for Health Equity at Vanderbilt, and Executive Director of the Mahara Vanderbilt Alliance. We are joined in that panel by Dr. Alex Jahangir. Dr. Jahangir is Professor of Orthopedic Surgery at Vanderbilt and Chair of the Metropolitan Nashville Board of Health, and that's really why he's here. He's leading the COVID pandemic here, the review of that. And lastly, Amy Richardson, Chief Community Health Officer of one of our immigrant indigent care clinics here in Nashville, Salome Health, Nashville, Tennessee. I'll turn the program over to Dr. Consuelo Wilkins, who will then moderate the session and kick it off. Thank you, Consuelo.
Thank you so much, Dr. Churchwell, and thanks to those of you who've joined us, as well as the other Chief Diversity leaders. I would like to start our session with just a brief overview of some of the work that we're doing here in Nashville at Vanderbilt. As part of our COVID-19 command center, early on, we embedded health equity as a work stream. So we actually have a large body of work that I, Dr. Churchwell, and many other key leaders within the VUMC community have been involved in since very early in the pandemic. We have several substreams focused on how we actually effectively communicate about the pandemic, how to make sure that testing and surveillance are equitable as well as care. And also very important for this pandemic, since there's no proven effective treatment, we actually have a focus on research. And because this pandemic has caused us to have to switch to virtual communication, we wanted to make sure that we weren't leaving people behind in adoption of telehealth. As part of that work, a key piece has been making sure that we have access to the data and being able to disaggregate that data by race, ethnicity, and language. And early on, we were able to identify some important populations who were more likely to be impacted by COVID-19. And those communities are actually individuals for whom English is not their primary language. So although we're seeing many disparities across the country, one of the disparities, inequities we're seeing at Vanderbilt University is this particular population. And that actually leads us to the panelists who are here today. As Dr. Churchwell mentioned, Dr. Jahangir has played a really important role in the city and county-wide response. And Amy Richardson, who has been really involved as the Chief Community Health Officer at one of our key clinics, community health centers in town, are really entrenched in this work as we try and make sure we're providing the best possible care for these communities. So Dr. Jahangir, I'll start with you.
Thank you so much for having me. And many of you are probably wondering what the heck is an orthopedic surgeon doing helping the city through a infectious disease process. And I sometimes ask myself that same question. And but in all sincerity, it has been an interesting experience in partnering, first of all, with what I think is really neat, being in both an academic medical center as a faculty member, but also serving this role in the city is really the synergy between the two organizations in Nashville has really paid off. Obviously, the work Dr. Wilkins is doing, but also the Department of Health Policy has been very instrumental, and infectious disease has been very instrumental. And I think that can be a model that can be used around the whole country of how the academic medical centers can really guide the response both at the local level and I think state level and honestly at a federal level. So I just very briefly want to talk about our experience here in Nashville, and then I'm turning over to my other panelist colleague, Ms. Richardson. As Dr. Wilkins mentioned, on March 8th, we had our first case of COVID-19 in Nashville. And very early on, we also started seeing what the Vanderbilt data was showing is really racial disparities of demographics in Nashville. To highlight some of those demographics, if for those of you who aren't as familiar with Nashville, 63% of our city is white, 28% African American, and 3% are of Asian race. And of ethnicity, only about 10% of the ethnicity of Nashville is Hispanic. But 12% of Nashvillians are foreign born and not native English speakers. And I actually am one of those individuals. So this is why this issue matters so much to me. In Nashville, we've had about 8,400 cases. And so, as I mentioned, 63% of individuals in Nashville were white, but 32% of our cases are of individuals who are white. And in the African American population, only 14% of our cases are in the African American community, which I think is really it's a whole nother topic of how that's wonderful to see. But 31% of our cases are in our Hispanic population. And in fact, I think there may be more than that because only 39% are non-Hispanic and 26% of people we have not been able to identify their ethnicity. So while only 10% of the population nationally is Hispanic, over 30%, and I would say probably closer to 40 to 50% of our population of this community is infected or of Hispanic ethnicity. And more so telling is 40% of all of our cases are in 2 zip codes in all of Nashville. And those 2 zip codes are in areas that are overwhelmingly Hispanic and foreign born. And most of those individuals are essential workers. And so I think that really led us to say, my gosh, we really need to focus on this, just like I think you've seen across the community. But I think this is where our partnerships have been critical. And I'll get into that in just 1 minute. So what do we do as a city? One of the first things we started doing was recognizing that as a city, we need to make sure testing is available to all our residents. We have 3 assessment centers that the city has put up, and those assessment centers are free to anyone that comes. Really, if you want a test, you'll get a test. And those 3 locations were strategically placed in our community where access to care has been limited. One of which being one of those 2 zip codes I mentioned earlier. And what's been really great to see is, on average, we're averaging about 5,000 tests in those sites, and the city as a whole is averaging about 8,000 tests. And of the people who are tested at our community assessment sites, 2/3 are non-white individuals. So we are at least getting out there in the community to do that. Furthermore, when it really comes to outreach, we kind of took a page from political campaigning, in that we really wanted to get a strong community organizations involved. We want to get a strong relationship with faith organizations and media. And we are starting to do this even more than we have in the first end, because our first efforts have shown that somewhat flattened the curve in at least one of those zip codes, but we really need to head further down. So what we have done is partnered with Siloam, which is what Ms. Richardson is involved with. And we've really been able to get out in the community, try to get more testing out. We've actually, in addition to our mobile testing centers have developed 1 and maybe 2 mobile testing centers. We've been able to hire contact tracers that are native language speakers, but also people who live in those communities that maybe there's some trust, because I think that's a big issue. and case managers, and Salome is really taking a lead here. Before I turn over, I do want to share one interesting fact about our mortality. The burden of disease, as you all know, while I just mentioned where it is in the communities, the severity and death, though, is very important to highlight in the African American community. As I mentioned, our city, while 28% Black, only has 14% of the cases in that community. But of the African Americans who are infected, 3.3% are dying, where our overall city mortality rate is 1.1%. And our mortality rate in people of Hispanic ethnicity is 0.5%. So I want to highlight, while I'm proud of the fact that our city and our leaders really have helped, the community leaders have helped kind of keep the infection rate low in our African American population, let's not make any mistake that community is not being impacted by this disease here in Nashville. And the mortality rate is literally 3 times what it is for the entire city, and 6 times what it is for our highest ethnicity. So we can have that dialogue further, but I didn't want to spend much more time. But Ms. Richardson would probably share a lot more about that community partnership we've done. Thank you.
Thanks so much, Alex. I think you're a great example of what I try to say all the time, is that a health equity leader doesn't have to have a specific specialty. So we accept you as an orthopedist in that role. And so next we'll turn to Amy Richardson. Amy, please go ahead.
Thank you. Thanks so much for allowing me to join this discussion and share about the work that we're seeing in the immigrant communities in Nashville. Sometimes I think that race data can be misleading. I doubt many of you would protest that point, because race alone doesn't always paint the whole picture. So as Dr. Jahangir mentioned, we are seeing language be a really important piece of the puzzle. And Salome Health is a nonprofit faith-based community organization that serves through a primary care clinic, but we also have a really strong community health worker program that we've been operating for 5 years. And it was through these 2 programs within our organization that we have seen the interactions with the immigrant community. About 95% of our patients are immigrants. So we knew early on some of the challenges that we expected these communities to face. A lot of them are essential workers, as we heard earlier. And additionally, they're living in multi-generational households, things that make COVID prevention really difficult. And so early on, we started trying to do education and outreach in these communities, but we've continued to see the challenges there. And I think one of the biggest challenges that's essential in any public health crisis is that building of trust. So I really appreciate the way that both the academic institutions and Dr. Jahangir and the health department have recognized the need to get out into the community using trusted channels. So not only with Salome, but also other community partners, we're listening to those voices. And the city has been working with us as well as other partners and other frontline organizations. We're having meetings together, sharing information, sharing what's working well and what's not working well. We have some really strong community leaders that are messaging to their own communities in specific ways. So in Dr. Wilkins' data, there was some information about the Nepali community. It's a pretty small refugee community, Nepali speakers, but they've done a great job of sort of self-organizing and building some care for one another. Their youth started a GoFundMe page. They sort of self-selected to keep a list of all the families in their communities that had been positive tests within the household. And so they were caring for one another, and that made our job easier because then we could help connect our community health worker to make sure they were connected to food resources or PPE and other things that they needed. So we see a lot of strengths within the immigrant community, but also still some challenges. There have been a lot of fear and the need to continue to build trust, particularly with communities, not just, I think, some of the expected fears for those who are undocumented and may not want to share their information with the government as they perceive it, the test centers, but even fear of not fully understanding what to do. So there has been a great effort across the country to get COVID education translated into many languages. But even deeper into that, we heard feedback that some non-English speakers were afraid to go to the test sites because they didn't know what to do once they got there. We even heard a story of a family who drove there, looked at it, couldn't figure out what to do next, and drove away. And so we've been able to, with the community health worker model and the health department, to produce some videos with native languages and trusted members of those communities who are able to sort of dispel some of those fears or lessen some of those fears. And so I think that's a really important piece of whatever we can do. It's not just the actual steps that are being taken, but the perception and the trust that's built along the way that's really important when we're reaching out to minority communities.
Thanks so much, Amy. I'm going to stick with you for the first question. You brought up trust several times, which I love to talk about. In this setting of a pandemic and a crisis, when there's so much information that people have to digest and try to understand how to use, what tips might you have for people who are trying to build trust quickly, get to these communities that are impacted? What would you say to that?
Yeah, it's definitely a challenge. If you haven't started yet, start now. I think that's one message. So one thing that I think is really important is find those trusted partners. That may be community organizations like my own, or it could be faith community leaders. It could be sort of block captains. So look for those people, and it may not always be the first ones you find. So sometimes the people that are most connected to an academic institution or to a particular, maybe a large Hispanic serving organization, those might be the best people, but they may not be. There may be sort of that layer of distrust. So talk to lots of people, find people on the ground, find out the formal communication channels and the informal ones. So for example, we have a lot of Facebook and WhatsApp messaging that happen in these communities. And those are harder. They're not necessarily the radio or the TV media channels. And so looking for those sort of informal channels of communication can be really important.
Great, thanks. Alex, you both talked about the language, and certainly what I shared with disaggregating the data by language was important. I find that a lot of places around the country are not focusing so much on preferred language or primary language, and that's obviously been a key here. But I wonder also what advice you might give to others. I've found you to be so responsive to new information when it's like, we need to collect this in the process of changing things, the way you collected data. Can you talk about that and how this has really been an iterative process?
Yeah, thank you. And this highlights exactly what we talked about the academic medical centers really helping cities and so forth. When we first started our process specifically around the community assessment centers, our goal was to get as many people as we could quickly. And sometimes, frankly, we might have taken certain shortcuts, right? So we're like, all we need to know is a phone number and then to get the test. And we realized that that's really not serving our most vulnerable populations effectively. And so thanks to you and others, we decided to gather, all right, let's gather data on race and ethnicity. Are we actually getting the testing done in those communities where we want? We didn't know that prior. We've added, or we're about to add perhaps language of, preference. So when we do, if somebody is positive, we can do contact tracing in the language of preference. And then also, it can also allow us at the assessment centers and to really have a sense of, do we have the right people who speak the language, or do we have the right graphics in the right languages? It's not just 2 languages, right? I mean, in Nashville, I think public schools are about 160 or so languages spoken. And so making sure that we're able to really give people that comfort. And I think Amy highlighted so well is trust. We could have a whole dialogue of how trust is something that in an attempt to be expedient, we in health may have not done well previously. And I think it's so critical. And so I think my big advice to people is trust is such a critical thing to gather, and language is, Amy said so perfectly, is we need to make sure that it happens. So thank you.
I'm going to get to a couple of questions. So one is in the question and answer box, and that is about genetic predisposition, since Black and Latinx communities are more impacted. I guess I'll start answering that one and say, as far as I know, there are no known genetic connections, but I also would take the opportunity just to remind everyone that race and ethnicity are social constructs. They're not tied to biology or genetics, although there may be some shared genetic, some genes or variants among populations. That is not how we define those social groups. And so I think we want to make sure we're not conflating that there's some genetic connection based on race or ethnicity. Another one of the pre-submitted, the questions submitted before the webinar focused on, the heat map, and you both talked about the southeast part of Nashville, where we have a higher concentration of individuals who are born outside the United States. Anything else you want to add before we move on to the next panel about how best to reach individuals based on geography, and anything else we should be thinking about as far as connecting those individuals, especially since social distancing can be difficult?
I mean, my big thing is find people like Amy and Salome and Turk and Conexion and people who are actually on the ground. And that's for the Spanish-speaking population, right? I think in other populations of African-American community, I think the relationship with the churches have been very strong. And relationship with Meharry Medical College, let's not highlight, we have an amazing academic medical center that is, African-American predominant medical center, which, I mean, Dr. Hildreth and what the group has done there has been really critical as well. So I think we're very fortunate in Nashville to have those relationships, both medicine and groups such as Shalom and others. So that's my 2 cents there.
Yeah. Amy, anything you'd like to add before we go?
I think continuing to build on the message of putting the resources where the need is. So Dr. Jahanger mentioned that where our community test sites were set up, but also continuing to listen to the communities. The mobile test sites that they're adding will be nights and weekends, which has been a gap for a lot of the kinds of workers that we've had in the city that are high risk. And so continuing to listen to your city and to the needs in the city or rural areas, listen to the needs of the groups that you're trying to reach.
Great. We do have some other questions. I will try to answer them offline and type responses there. So please keep an eye out on the Q&A. Alex and Amy, thanks so much for your time. And Alex, thanks for mentioning Meharry. Meharry Medical College is now leading the community testing sites here in Nashville. And I'm sure much of the success will rely on the many years of trust the community has in Meharry. So I'll turn it back over to you, Dr. Churchwell.
You're on mute, Dr. Churchwell.
Dr. Churchwell, we don't hear you.
Dr. Churchwell, you're on mute.
Thank you. Well, that was lovely. I spoke a lot of nice things to myself. Great team effort. And I'm going to pass the baton now to my colleague, Antonio Ferris, who's the Chief Diversity Officer down at the University of Florida. We'll pass it southward. Thank you, Antonio.
Thank you, Dr. Churchwell. It's my pleasure to introduce a distinguished panel here that includes Dr. Leon Haley, who serves as the CEO of UF Health Jacksonville. He is the Dean for the University of Florida College of Medicine, Jacksonville. And if that's not enough, he's also the Vice President for Health Affairs at the University of Florida and a Professor of Emergency Medicine. Dr. Haley brings a wealth of experience as in both the CEO and dean position. He completed his undergrad at Brown University and his MD at the University of Pittsburgh, and somehow managed to squeeze in a master's degree from the University of Michigan as well. I also want to introduce the panelists, who are Dr. Yvette Murphy-Irby, who is a professor of social work and also the vice chancellor for diversity and inclusion at the University of Arkansas. She is also an accomplished scholar and a leader and administrator, and has extensive experience in leading change in organizations, particularly related to addressing structural, institutional, and systemic challenges. She holds a BA from UNC Charlotte, MSW from UNC Chapel Hill, and a PhD from UNC Greensboro. Since joining the University of Arkansas as a faculty member in 2004, Dr. Murphy-Irby has received over $17 million in external funding awards from NIH, NSF, HRSA, as well as state and federal funders. And last but certainly not least, in terms of our panelists, is Dr. Adrian Tyndall, who serves as the interim dean for the College of Medicine in Gainesville at the University of Florida. A graduate of the University of Maryland School of Medicine, he completed his residency in emergency medicine at the University of Maryland Medical Center. He's board certified in emergency medicine and is a fellow at the American College of Emergency Physicians. He holds an executive master's degree in health services management and a health policy from the Mailman School of Public Health at Columbia University. All our panelists have extensive leadership experience. They serve on several boards across the country and in local areas. And at this point, I turn it over to Dr. Haley, who is going to be the moderator for this panel. Dr. Haley?
Thank you, Antonio. I really appreciate that introduction. And certainly I want to thank the last panel for getting us off to a really great start. And really appreciate all the information that's being shared. I'm just going to share my screen and just say a couple of overarching statements about the state of Florida, which is right now one of the current hotspots as it relates to COVID. You've probably been watching that on the news. And actually, as I remind our team on a regular basis, let's not worry about the second wave of COVID. We are still very much in the first wave. I can just tell you at our hospital, we've seen a doubling of our hospitalized cases in just the past week. And you've seen similar things across the hospitals in the state. State of Florida does have well over 100,000 cases at this point, well over 3,000 deaths. In Duval County, which encompasses and is the same thing as the city of Jacksonville, we've had about 3,200 cases and 62 deaths. What you have on the screen is a dashboard that we use, one of several actually. One of the things that probably for many of you as well that's come out of COVID is really a great teamwork with our IT and data analytics team to put together daily dashboards for us, which we do on a regular basis. But every couple of weeks, we put together a very quick snapshot of the patient profile in the hospital and all of our hospitalized patients. We've actually hospitalized about 65 patients at this time. This one is about 2 weeks old. So we do update it, but the numbers haven't changed dramatically. And just a couple of key findings, you can see the male-female breakdown. So primarily female in our organization at this point. The racial breakup is 56% Black, 31% white. That is almost the exact opposite of what the city of Jacksonville is at this point, which is generally 60% white and 30% Black. And that just gives you a quick snapshot of the things that we've been seeing in terms of this racial and ethnic mix in our organization. The other nice thing about this dashboard, and we've heard a lot of conversation about pre-existing medical conditions, and you can see that the patients that have been hospitalized in our organization really do have a significant degree of pre-existing conditions, ranging from obesity to hyperlipidemia to diabetes as a whole, and hypertension. The other nice thing about our dashboard is we can locate the hotspots in the community. And they are those that are unique to our patients and those that are in the region. The one thing that is interesting is the hotspot of the hospital is 32209, but the vast majority of cases actually in the city of Jacksonville have been in 32207, which is approximately 10 blocks away. Interesting enough, it has one of the highest life expectancies in the state compared to ours, but they've actually had the most COVID cases at this point. So a very unique, one of the things that doesn't fit what has been the typical pattern across across the state and across the region for us. So I'll stop my screen from sharing. I know we've got a great panel who want to share some great data with you. The last thing I'll say is once we started recognizing some of the hotspots, the city had been doing community testing in a couple of different locations, but all of which actually required you to have a vehicle. So we made a decision as a health system to actually go into some of the African American and Hispanic communities in the Duval County, city of Jacksonville area, and really just took our team on the road. Through that, between both a research arm and a clinical arm, we tested about 2,000 people thanks to some lab kits from the state. I will tell you that the overall community positivity rate was extremely low. And a little bit different than what you've seen and heard about as it relates to the asymptomatic carriers. But I'll stop there. I'm going to have Dr. Murphy Irby speak first and give a few overarching comments, and then we'll switch to Dr. Tindo, and then we'll make sure that the panel has plenty of time for questions. Dr. Irby.
Good afternoon, and thank you very much. I just want to introduce into the conversation the importance of community. I think we've talked about that, but it really is important that we be really intentional to embrace community in a real broad sense and in a very specific way. And so as we think about interventions and we think about what are the challenges, we have to ask ourselves the big why. And when we answer that question, we cannot leave out the fact that it really is about racism and racial disparities. And we can look at the inequities that are existing all across our nation in every major social institutions. The evidence is there. And so when we think about how can we do something different this time, it really is about community. How do we engage communities from a variety of standpoints and really try to make sure that our efforts and our interventions are culturally relevant? And by that, I mean, things are going to play out and carry different meanings for different communities. And so there are language barriers, yes, and that's really important. But the way things play or the way things mean and the way they translate into communities are also very different. We also know that as we heard earlier, our zip codes are really important. And zip codes will carry and bring forth different types of dynamics. Some communities have extreme food deserts, which plays into our health and our well-being. We see things like redlining and sort of the way the housing is congregated or put together or not. So there's so many things that really play out, and those things are going to carry very different meanings for very different communities. And so if we really want to be effective, it really does mean we have to step away from business as usual. I love to hear that in Florida, they're going out into the community. But so not only going out into the community, that's a major step, and that's a very important step, but engaging what I call, or what the research calls, is a community-based participatory model. And what that means is that we really are engaging community and looking at every single aspect, from the questions we are asking, how are we collecting the data, how are we interpreting those findings, how are we thinking about what interventions need to be in place, and how those interventions need to be organized. So it's different. It means that we have to get out of our places of employment. We have to get out of our educational institutions, and we have to do a better job of engaging community members as true partners, not as just a place where we go to collect data or go to sort of hear what we're wanting to hear or gather information, but how do we engage as true partners? Thank you.
Thank you, Dr. Irby. Dr. Tyndall.
Thank you, Dr. Haley. So a couple of arching comments, and then I want to talk to you specifically about our experience in Gainesville, which has really been interesting, perhaps because of our geography. Now, first of all, I before coming to Gainesville, I actually worked as an emergency physician in New York City and Brooklyn. So a lot of my colleagues are still there. And as you can imagine, the experience, especially in terms of what COVID-19 has done in terms of basically uncovering the deep-seated structural issues in our health system and our society, I think is really the key item to really think through as we think about the impact we want to make, and now that we've had this realization. Very early on in this process, I would say at the time that COVID began to hit, myself, along with a few other African-American deans across the country, really teamed up with Selwyn from Alabama to write an op-ed that was published in USA Today that was focused on just this, that we really were beginning to see incredible disparities in terms of how COVID-19 was raging through society. And we really talked about what it was uncovering, which I think were really issues that have existed that we perhaps have grappled with, but have not clearly solved. And now the coronavirus basically uncovered all of these ills. So I want to turn attention to some of the contrasting things, because I think that, you know, geographic environments and other areas sometimes makes a bit difference in terms of the experience, but also I think pulls out other issues that we aren't always thinking about. So Gainesville, Florida is a university town, and you know, which means, and it's a small university town. You know, we do have a fairly significant African American population within their city limits and as part of our community. But as you might imagine, a large part of the population has to do with the coming and goings of students. So very early on, part of the avoidance was to try to get the students back to their locations and away from Gainesville, which I think worked really for quite a while. The point, though, too, is that UF Health in Gainesville really serves a fairly large catchment area, which is also largely rural. And in that rural population, I think there are other significant challenges outside of the urban area. So one of the things that challenges us, for instance, are the migrant farm workers. And so very recently, some of the spikes that we've actually seen in our COVID transmission rates have been amongst migrant farm workers. So there have been real challenges presented to us because geography, but there was also some interesting findings. Early on, UF Health, just like what Jacksonville did, went out to the community. We took a couple of, I think, very early and important steps, I think, to understand what was happening in our community. We rolled out a first responder testing program. Basically, we wanted to look at our paramedics and EMTs and firefighters and police and folks who actually were encountering, you know, face-to-face without really the ability to not social distance amongst many of our population. We went out to our homeless shelters and areas within our community where there were a lot of homeless to really understand what was happening in those areas. And then most recently, too, we have expanded our testing specifically to city workers who are oftentimes overrepresented in terms of race and ethnicity, especially African American. And so we have looked at our bus drivers and our sanitation workers and others because they are not only most vulnerable because of exposures, they're critical workers within our system. And I think when we're doing that very specifically because we understand that that's actually part of the social fabric of what we're facing, that there are groups of people who are in such conditions structurally that prevents them from essentially avoiding, you know, transmission of this disease, and that's really a critical issue. Early on, I would mention that just like Jacksonville, and I was really surprised that the prevalence rates were extraordinarily low. Our first batch of testing, which went from early March through June, indicated a less than 1%. A matter of fact, a 0.6% positivity rate within our immediate community, with pockets of activities in our surrounding rural areas. And if you look across the North Central Florida, you're seeing that sort of activity. I think what's concerning is perhaps what you're beginning to see now, that in other areas of the country, the numbers of hospitalizations and rates of test positivity has decreased substantially. But we're beginning to see this now unfold in other areas across the country. And the point is we begin to understand this disease even more. There are more and more questions we actually have to answer about the natural history of the disease and how this happens. For instance, one of the concerns that we have is that because of the low positivity rate, we probably have little to no herd immunity. And given that, if we have a surge in terms of exposure of virus, how can that actually now impact our population? That becomes really very important. So the critical piece to this, I think, is that we have to be able to understand what's happening in our populations, especially those vulnerable populations. We have to understand where those vulnerable populations are and to really target them in a very important way. And I think the bottom line is that we won't fix this unless we fix really the underlying structural issues within our society that makes groups of people much more vulnerable to the disease, outside of things like what we might think are the typical comorbidities, because it's not just that. It's the calculus of the comorbidities plus all the other things that have been really endemic within our institutions and our communities that's really causing this tragedy that we're beginning to see today. In order to combat this, we can't necessarily be targeted. We have to be comprehensive in our approach. So Leon, back to you.
Great. Thank you, Dr. Tindo and Dr. Irby. So a lot of really great information. So I throw this back to both of you because you both brought it up in kind of different ways. But Dr. Irby, can you talk a little bit more about the community engagement with the healthcare community, and what does that best look like to kind of meet the objectives you talk through? And then a secondary piece, probably for Dr. Tindo, based upon what he just asked, is how do we, knowing that other structural components of disparities, whether the education system, where people live, how do we in the healthcare community try and bridge those gaps?
Yeah, so I'll start by saying that so the University of Arkansas is located in Northwest Arkansas, the northwestern part of the state. And we're home, this area, this region is home to the largest Marshallese population outside of the Marshall Islands, right here in Northwest Arkansas. And so our Marshallese community and our Latinx community are being hit hardest in our Northwest Arkansas region. And so the CDC has come in and really working with the community to try to understand and sort of really hear. But I believe that it really is important that we have those relationships with communities, a variety of communities, all communities, that one-on-one relationship, meaning that we treat them and we engage them as true partners throughout a process and not just when a crisis occurs. And so what does that look like? That looks like that we engage with them in real ways, in ways that are meaningful to the community. And so we talk with them about how is it that we can come together as partners. And then when we come to the table and have conversations, that they're included and treated as the experts that they are. Their expertise on their communities, their needs are far greater than ours. And so it involves a lot of listening, but it involves us also doing things in a very different way. And there's some practical strategies that we think of oftentimes when we are engaging communities. And that really is right down to when are we scheduling meetings? When are we going into communities? What types of things how are we setting those up? Even right down to sort of the snacks and things that we provide. Are those things that resonate with the community? And are we talking with the community about those kinds of needs? Again, that helps to build that trust. And I think once we have that trust in place, and that, again, that's a steady process, but that trust then helps us all to work more collaboratively.
Dr. Tindo, your thoughts?
Yes. So I actually really completely agree with that strategy. I want to take it one step further too, because we realize that, you know, when we talk about community engagement, we have to understand what that really means. And it oftentimes means exactly what you said. It's truly a partnership in terms of bringing the experts who are in the community to the table, so that we can understand really what is truly needed. Because there's nothing worse than the misapplication of resources. And oftentimes that happens when we don't quite understand what's needed. But the other piece to it is that oftentimes you do understand what's needed, and still there are resource constraints that prevents us from deploying those resources in areas that are truly needed. So I think part of it is understanding or having the conversation to understand what those risks are. The risks to those folks who are, I think, really critical workers in our community. As you probably saw this happen in New York, people come to work because they have to come to work. They have no option to stay at home or to have an alternate work, sort of plan. They have to be at work. Did we recognize that? And when did they get then the kind of protective equipment that was needed for them to carry on that work? Should we have not recognized that earlier and put those protective equipment in place to prevent them from actually, getting disease. These are the things we have to think about, and unfortunately, those become afterthoughts in our process, and we can't afford to do that. So I believe very strongly that there are things that we need to do that will obviously impact this significantly. And it simply just can't be. So I think we could do all the testing in the world, which helps us to understand what has to happen. But then we've got to focus on how do we prevent it? What are the resources that are needed in the next steps beyond testing to really sort of protect and prevent people from getting the disease? How do we do things that help to strengthen things like, the living conditions or working circumstances? All of these require resources. And I think we cannot shy away from the resources required in order to really make a difference. And I think that has been, frankly speaking, the thing that's prevented forward movement is the allocation of the appropriate resources to ensure that a difference can be made and an impact can be made.
Right. And I just want to add to that. I completely agree. I think, and then the next step is really making sure that we are making the necessary policy changes. That, right, we have to change things at the policy level, the policies that govern us as a society and our various institutions. That also has an impact on how those resources can and are able to flow.
Great. I know we're running short on time, but there's one I want to shift gears just a little bit. Maybe this is directed towards you, Dr. Tyndall, a little bit more. It was one of the pre-questions. Somebody was asking about engaging students of color in COVID and many of the things that are going on. Because in the midst of COVID, we were all witness to the very public deaths of George Taylor and Ahmaud Arbery and a number of George Floyd, and a number of other folks. So talk about engaging students of color in COVID and racism and what's going on and how the university is approaching that.
Thank you. I would tell you how the College of Medicine is really approaching this. As you might understand, this is, if you think about, I think of this as a sort of a scab. Every time something like this happens, there's a scab that's ripped off of a wound that opens back up. And I think the George Floyd incident was just one of those things, which I think uncovered in so many ways a brutal reality about the impact on students, what was happening in our clinical environment. And all of a sudden, students came forward. And I was so proud, and I'll tell you why. Students came forward and were able to bring up and talk about their experiences they had not been able to talk about before. So we had a series of town halls listening to students. And it was really important for us to hear, not just from our Black students, but from our students from other ethnic backgrounds who were pointing out, times where there were microaggressions and other issues within our environment, and also pointing out that this, especially with the corona, really kind of resulted in a clear need, or there was a gap within our education infrastructure to really understand how the structural issues, how racism, and how really, I think, decades of economic impact has really adversely impacted healthcare and healthcare delivery. So there was this hunger for more in terms of understanding, not issues just of cultural competency, but really understanding what's happening in our community. And so a group of students got together and created a JEDI task force. And if I were to tell you the acronym, I'll probably get it wrong, but it was a really neat acronym. And the students ranged from first to fourth year, fully diverse, all groups, all ethnicities. And they got together to really create a plan and to propose to the institution of the College of Medicine a series of steps that perhaps we can take to really improve not just the education environment even more, but to really dig deeper into their experiences, and then also to really create modifications in our curriculum to really help students of all colors and backgrounds really understand what's happening at the interface of the community and healthcare system. I was really proud of it. I was proud of it because their turnaround time was much shorter than the faculty effort. But this has really been a tremendous impact. But I have to say too, it's been a tremendous opportunity. So when we think about all of the the issues that we're seeing now that has resulted essentially because of the sacrifice of George Floyd and what has happened within our community. We need to understand that this has also impacted the fabric of our medical education, and I believe is actually going to result in some substantive changes in the future. So thanks for that question. It's really important.
Thank you. Well, unfortunately, we're out of time. These panels move very quickly, so I'm sure Dr. Tindo and Dr. Irby can look into the chat and Q&A function and answer questions if appropriate. So I will thank you both for being here. Thank you for sharing your expertise. Dr. Churchwell, back to you.
And let me say thank you again, Dr. Haley, Dr. Tyndall, and Dr. Murphy Irby. And with that, I want to move this panel over to our esteemed colleague and Chief Diversity Officer, Vice President and Associate Provost at the University of Alabama, Dr. Christine Taylor. Dr. Taylor, it's all yours.
Thank you so very much. It's a pleasure to be here, and I'm excited to introduce our next moderator and group of panelists. The moderator for this session is going to be Dr. Pamela Payne Foster, who is a professor of community medicine and population health. She's also the deputy director of the Institute for Rural Health Research here at the University of Alabama. Also joined on this part of the discussion is, for our panelists, is Dr. Corey Herbert, who is at the Louisiana State University School of Medicine. He's also the chief medical editor and correspondent for Black News Channel BNC. And finally, one of our panelists is Ms. Felicia Lucky, who is the executive director of the Black Belt Community Foundation in Selma, Alabama. It's my pleasure now to turn over this part of the discussion to Dr. Pamela Payne Foster.
Thank you, Dr. Taylor. And thank you. I just want to give a couple of introduction before we get to our panelists. I'm at the University of Alabama School of Medicine, but I'm at a branch campus, which really serves rural Alabama. And I am a translational scientist, and one of my communities that I serve is the Alabama Black Belt. The Black Belt being 12 to 17 counties that run centrally throughout Alabama. Traditionally, predominantly African-American, rural, and poor, with poor health outcomes. I have usually worked with communities, and we've been talking about partnerships, one-on-one with community-based organizations to really do this work. But about a year ago, I thought about bringing together 5 community-based organizations in the Black Belt and call it the Black Belt Collective, to really see if we could begin to have a little bit more impact in this area. One of the panelists, Felicia Lucky, is one of our partners. Honestly, when I pulled this together and talked with them about it, it was really to go after grant funding and really come at it from the research point of view, community-based participatory research. But as COVID-19 hit, it became much more than that for both my community partners and myself being in an academic health center. It really served as a great venue for us to have communication between our community partners to see what they needed, how we could help them, what resources they could use. I was getting calls from all over the country for donations for PPE and donations for even testing. And so connecting, having that collective to connect with those community partners who really range in areas from mental health, chronic disease, faith-based health, was imperative. We, as an academic health center, and let me just say, in Alabama, like most of the South, we are disproportionately, African Americans are disproportionately affected with the infection as well as death rates, between 40 and 50%. But we were actually approached by a mayor of one of the cities in rural Sumter County to do testing early on. This was last week in March, at the beginning of the epidemic. We really didn't know the burden at the time because we weren't collecting numbers and had no idea. But when we started, it was a grant. We got grant funding from Alabama Power Foundation to really do free testing. We have since that time seen 518 persons in 3 Black Belt counties. We have tested about 358 of those and 45 positives, with really a very high positivity rate of between 12, 15%. positivity rate. So going out, we have a mobile van, we were going out doing the testing. I was able to kind of see firsthand these clusters, essential workers, healthcare workers, and hear those stories, which really resonated with me to continue to do this work. The other message, just got a call this week from another mayor in Hobson City, is an unincorporated town in rural northern Alabama, where they did testing. They had about 100 people come out, which is a great number for a small town, but she was really disturbed because one of the residents said, if they get a vaccine, if they come out with a vaccine for COVID, I'm not taking it. Because you remember the Tuskegee syphilis experiment. So I bring that story up because I'm also, and I'm sure Felicia, our panelists, Felicia Lucky and Dr. Hebert will attest to the need for more health messaging. We're not getting people wearing masks. They're not really understanding the importance of wearing masks to really get at this epidemic. So I open up and I will start with you, Ms. Lucky, to give us some of the things you've been seeing in your community, and then we'll go to Dr. Hebert.
Wonderful. Thank you so much. It is indeed a pleasure and honor to be with you today. Again, we do serve 12 rural counties in the state of Alabama. And as Dr. Pam has just suggested, many of those communities all have very similar different demographics, which make us very attractive to research institutions oftentimes. And we do know and understand that part of what we're working to do is to take advantage of the attraction by research institutions so that we use it for good for both the institution as well as for our communities. Much of what we're seeing throughout our region is just as Dr. Pam mentioned, just that many, the amount of testing is not readily available in many of our counties. And I always say that if you close your eyes as you're driving from one county to the next, you really wouldn't be able to tell the difference because they all look the same. The demographics are all the same. So when we talk about, I received a call the other day just to bring it very close to home, saying that there were sanitation workers in Macon County, Alabama, which is home to Tuskegee University, my alma mater, by the way. And they said that they did not have PPE at all to do their work. So we've been approached as a foundation, as a philanthropic institution to help try to meet the needs of those communities. So it appears that there is a desire by others to wear masks in some instances, specifically with the jobs, but then it's not always readily available. How do we equip our courthouses? And we know that resources there were very tight pre-COVID, and they're even tighter now that we're at COVID or during COVID. So we have to find alternative ways that we can really equip our communities. And it is sometimes requiring us to work very differently than most urban centers do. You're on mute.
Dr. Hebert.
Yes, I just want to thank everyone for allowing me to come and speak my truth here, because we've down in New Orleans, we've had a lot of truth to speak. We were one of the first hotspots where people started seeing this 70% of people dying were African Americans here. So it's almost like we spoke before, a doctor, to say what I wanted to discuss, because it's all about messaging. Just as an aside, I'm the chief medical editor, she mentioned, of Black News Channel, but also a contributor to CNN and MSNBC, and the chief medical editor for NBC for the Southeastern region here in Louisiana. So the messaging has been a real problem. And I agree with almost everything Dr. Fauci always says, except when he said, we're going to shine a light. This is shining a light on the disparity of African Americans in health. And I just want to throw a couple of things out there at you. I always like to say inequity, because when we say disparity, the difference between an inequity and disparity is just a difference, meaning disparity is just something different. Doesn't mean that it's worse or if it's better. So we like to say inequity because it's not good. The inequities that we have, they are not equal. So as far as nomenclature, these kind of things fall on our minds, and we don't think that it's necessarily unequal when we say disparity, even though a lot of people do. So just think about that. But also the messaging is basically a problem when we talk about, as Dr. Fauci mentioned, we're shining a light. The light has been shining a long time. We spend millions, billions of dollars on health inequities in this country for many, many years. But outcomes aren't where we need them to be. So it's either the message or the messenger. And that is the problem, because if we continue to do things that are not effective, then we are spinning our wheels and losing money. So, and with the money we use to get these messages out, we have to make sure that we are getting a return on investment daily. So what we started to see in Louisiana and New Orleans is that the messaging was just falling on deaf ears. The first message that came out on social media is that Black people can't get coronavirus and COVID-19. That was a bad message. Set us back a little bit. And then when we started talking about the other messaging, we had some of our elected officials come out and say, you know, Black people, you need to quit smoking and you know, stop eating fried chicken and stop doing these things. You can't blame people without framing a situation. So I just want to kind of go into the social determinants of health real quick, because we know it's where we live, where we love, where we work, where we play, those things. But the World Health Organization also defines it, and I'm going to read it. It says, those determinants, these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local level. So never say the social determinants of health without mentioning that second line in the definition, because we cannot blame people for things without framing things. So when you look at where I live, if you tell me to quit smoking and quit eating poor, bad food, but there is no place where I can buy with the job that I have and the bodega on my corner where I can afford broccoli, or I can buy it freshly. If you can't frame that for someone and then you tell them to eat appropriately, then that message is off and that person is not going to adhere to what you're asking. So what we had to realize is that the message has to come from someone that is trustworthy, as we've mentioned before, but also the message has to come from a trusted source. And and just because we're all here, we're erudite people, we have PhDs and MDs and MPHs, it may not need to come from us. And that's an ego we have to check at the door, because we feel like, you know, we can get to people because we know what to do. But we may know what to do, but we may not really know how to execute it, but also make the people feel very comfortable. I went to Meharry Medical College and went to Morehouse School of Medicine, and I'm the chief medical officer at Dillard. I went to Meharry. I've seen how we can have an interesting group of Meharians go to a place in Nashville, and sometimes the Black people just don't want to hear it because they're like, you're not from here. I don't like the timbre in your voice. You don't understand my pain, all these things. So we've had to realize some of these things that are very serious as far as getting these messages out. So there are a couple of things I want to talk about that, and I know we have time, so just make sure you just do like this when you tell me to cut.
I want you to just make it short so we can get to a couple of follow-up, because you gave
and I'm gonna just address a couple of things that were mentioned. The vaccine, the clinical trials. We know about the Tuskegee experiment, but if you ask most Black people, they still feel like Black people were injected with syphilis, which that did not happen. Now, don't get me wrong. It was the most egregious thing that could ever happen to withhold medicine from people. But I just want people to always have the right information. That's the second thing. The third thing is that we have to think about, we talked about the genetics and predisposition. We can't forget that there are lots of things that make us different. They don't necessarily directly affect our health that make us different. But when we talk about sickle cell disease versus sickle cell trait and these COVID-19 cases, this is a really important index of mind that we're looking into, because we know there's 100,000 people in America that have sickle cell disease, but there's 4 million Black people that have sickle cell trait. And that trait now we know is not just dormant. That trait causes, when you have stress, that trait causes a lot of physical discomfort, as well as decreased oxygen and hypoxia. So much so that all of our universities, if you have sickle cell trait, you have to go through a second level of screening, because 15 African-American men have dropped dead in Division I sports on a football field from sickle cell trait, but having that crisis on the football field. So those are things that we have to look at, because with the respiratory disease, that may be some of the issue too. So with all that being said, the adherence. Make the community feel like that the culture is being lost. You can't yell at people and tell them to wear a mask. You can't just tell them to do things. You have to say, look, you want your grandmother to be around. You want to get that recipe. You want to get that story. I need you to wear a mask to preserve the African-American culture. And that's part of your responsibility. So I'll stop right there so we can have some questions.
Thank you so much. I just wanted to follow up on your point about inequities, the unequal playing fields around resources and power. I do agree with you, Dr. Hebert. I'm going to start with you, Ms. Lucky. Can you talk from the community perspective about what strategies should probably be used to try to equal up the playing field? And then I'll go to you, Dr. Hebert, maybe from an academic health center standpoint.
Sure, I think very similar to what was said earlier. There has to be in pulling the community into the work, there has to be a true respect and trust of the community. I think to include those who are most affected by the situation into the discussion, into the leadership portion of it. So oftentimes we craft solutions without those being at the table. And I could just tell you, even here in the state of Alabama, as we're working with communities to access CARES Act funding that has come down from the federal government, we're having to work very closely with many of our smaller minority communities to equip them so that they can access those dollars. Because what we're seeing is that for a while, the zip code is pretty much determining whether or not they will have access to really protect their communities. And so it requires work of a very different kind, work that most folks don't want to fund. But if we don't do it, then more communities that are Black and brown will not have access to those dollars where those communities can then be safe. So we have quite a few instances of that in our communities, but we've learned that even as we talk with our governor and our state finance directors, if you pull educators from the Black Belt region, who we know some of our counties are some of the poorest counties in the nation, if you pull some of those superintendents there to help you map out the solutions to what needs to take place in the state, then you don't have a lopsided solution. You have a solution that works best in urban and rural centers. And if you know the Black broadband is an issue, if you have a rural superintendent at the table, you don't craft a solution that does not factor in the fact that all communities don't have broadband. So really bringing community to the table, trusting community when they're there, acknowledging the wrongs or misconducts that may have gone on along the way so that you earn their trust and consider them to be a true partner. I know oftentimes if I go into a room, if I'm in a room or enter into a room with many who may have a PhD and I do not, then sometimes my voice is not heard or always welcomed. And I always say that we respect those in our communities as having a PhD in community, and we value them because that's the only way we dig deep into where communities are to actually be effective in our work.
Amen. I like that term, PhD in community. I like that.
Yeah.
Dr. Hebert?
Yes, I think at an academic institution, I mean, we're grappling right now with reopening our university at Dillard University and LSU as well. It's hard to go against the grain of a state when the state is trying to open phase 3 and say that it's just everybody just deal with it. We'll be fine. Herd immunity will be met. And then you have parents calling in saying, do we want our child to come to the university, and how can that be? Where will they eat? How will they interact? So what we found is that doing it multi-generationally, it looks like for our community is starting to work, meaning that we get key stakeholders in the younger population, meaning that 18, 19-year-old population, as well as in the population, and I'm not going to say elderly population because I think that's an offensive term, people over the age
Elders.
of 65. Yeah, my elders, not by much. And trying to make sure that we get this generation to generation uptick in trying to protect each other, because we are a very interesting group when it comes to family and community, and we have to have them to understand that we need to protect from the top to the bottom. So let's just say, for example, when you go to a big gathering, whether it be a rally, whether it be some type of party, you go back to your pod and you expose all these folks. So we have to explain to the folks that, first of all, and this is at the university level, that, and we're doing a lot of messaging to that you are not just hurting yourself, you're hurting your community. So it's your responsibility to do that. But with our messaging through LSU, we are doing the use your head, stop the spread. So, you know, it's a kind of a kitschy, kind of colloquial feeling, but you're seeing all of our local celebrities, all of our local politicians, everybody get into this use your head, stop the spread in a way that makes people feel very comfortable, so that they will have the message and take it in and adhere to the message. So that's what we're doing at the academic level.
Okay, I have one last question because I think we're running out of time, and I'm going to get this from the chat. And it says here, I know you are all medical, but Miss Lucky, that doesn't include you. But can you give a message that includes choosing not to wear a mask contributes to a poor economy, not wearing masks contributes to a spread which has associated health costs, but it also can contribute to slowing to opening the economy. Some do not care about others' health, but might care more about money. So reframing the public health reasons to wear masks to economic.
Yeah.
Can you both speak to that?
Yeah, I'm a little bit concerned about it because, as you've seen in some of our elected officials, we've been told that we should kind of pad this data a little bit, and whether this data may be that we're using antibody tests and then using the PCR and lumping them at the same so we can say that we've had a lot of testing, or removing the testing altogether so that we can say that the numbers aren't going up so you can justify the economics. All these things are at play, and as a public health professional, I've always said that public health is a four-legged stool. You have economics, you have politics, you have public outcry, and you have science. Science should be number one, but the other three are the big dogs on the stool. So what we have to remember is that keeping science at the forefront, it will make it so that we can tamp down a lot of the politics. But economics runs this country, it drives this country. It drove the epidemic in 1918, and we should not call it the Spanish flu because the Spanish didn't have much more to do with it than anybody else. They were just honest enough to say that they had cases. So it was the H1N1 flu of 1918, but they had the same issues back then. Economics runs this situation. So we have to stand up and say, we must do what we need to do for the science, not the public outcry or the politics or the money.
Ms. Lucky?
Yes, I think the message has to be crafted a little differently for many of those in the communities, because I think for many that we're serving, where we have poorer communities where economics has not been our friend, that the message of it's slowing down the economy is not one that will be favorably looked upon or even considered during that time. And it is because people have been in a place where they're continuing to struggle, just trying to find food, as we mentioned earlier about food deserts, just trying to reach some of their basic needs. And so understanding and hearing a message around the effects on the economy may not take very well to many of the residents that we have, but I think that we do have to really help folks understand and talk in the language that resonates very strongly with them in order to see and affect the change along the way. But for many of our areas, if we've had high unemployment, if we have very low median income levels, if most of our communities are persistently poverty communities, the effect of the economy has been more of an enemy to them than a friend. So I think talking from the science standpoint of it is definitely much more helpful.
Well, thank both of you so much. I think we're out of time, but we really do appreciate your insights. And I'll turn it back over to Dr. Taylor.
Thank you so much to our outstanding panel. We want to thank again Dr. Pamela Payne-Foster, Dr. Corey Ebere, and Ms. Felicia Lucky. We turn now to the conversation that's going to be happening with our CDO at the University of Kentucky, Dr. Sanja Feast-Price. Sanja?
Hello, everyone, and thank you for what has been thus far a phenomenal opportunity to learn from our distinguished colleagues throughout the country. I'd like to begin by introducing our dynamic panel to you. First is Dr. Anita Fernander, founder and chair of the Lexington-Fayette County Health Disparities Coalition. Dr. Fernander is also the Associate Professor of Behavioral Science in the College of Medicine here at the University of Kentucky. We have Dr. Michael Brown, professor in the School of Kinesiology at Auburn University. And last, but certainly not least, we have Senator Reginald Thomas, Kentucky State Senate. He is the senator of the 13th Senatorial District of Lexington, Kentucky. Without further ado, I will turn things over to Dr. Anita Fernander, our moderator. Thank you.
Thank you so much, Sanja. I'm going to see if I can share a couple screens with you first. Let's see here, there we go. Hope you all are seeing that. So to date, the Commonwealth of Kentucky has had over 14,000 positive cases of COVID-19 and over 500 COVID-19 related deaths. Of the racial groups for which race is known, African Americans disproportionately make up 15% of COVID-19 cases and 16% of deaths, while only making up 8% of the population within the Commonwealth. The majority of our COVID-19 cases here are in counties that cover Louisville, Lexington, and Bowling Green. So after the first case was reported in Kentucky on March 6th, cases peaked around during the month of April, but there appears to be early indication of an uptick in the number of infections. And just briefly, I want to address efforts in the area of practice, research, and community. Are you all seeing that graph on the screen? No? Okay, that just means I don't know how to work Zoom properly. So we're not gonna hold this up. I'm gonna continue. All right, so in the area of practice, the efforts have primarily been in the area of stressing the importance of physically distancing, increasing healthcare capacity, as well as increasing testing. And one of the challenges, as in many other communities, is the lack of testing accessibility for those populations and communities that have been most adversely impacted. And an emphasis was put on having testing sites placed in communities of color. And there are now over 205 testing locations across the state. As far as research efforts are concerned, here at the University of Kentucky, as well as private health and research foundations, they have created specific RFAs to not only examine COVID-19 etiology in the general population, but to examine COVID-19 in communities that are also adversely impacted. The COVID-19 pandemic and recent attention to African Americans dying at the hands of police have laid bare stark structural and systemic racial inequities in our communities across the country. And while the two epidemics of COVID-19 and police brutality have brought social, political, and health disparities and inequities into sharp focus, they're not new. We know since Blacks set foot on US soil, there have been disparities among Blacks in the US. Our two national pandemics of COVID-19 and police brutality have placed a magnifying glass on the realities of racial inequities that have remained unrecognized or have been ignored by the larger society. I really feel it is important that historical and contemporary understanding is needed to recognize the structural and systemic social and political barriers that underlie these disparities, and to catalyze the social justice work that's required to address them. I was going to also share at this point just 3 op-eds that myself and colleagues have written for our local newspaper to begin educating our community about some of the historical and contemporary foundations. I will share links to these op-eds in the chat box. So social justice efforts have to be coalesced across networks that include multiple disciplines and fields using cross-sector collaborative strategies to address complex and multi-layered structures and systems. So one of the ways in the area of community and coalition efforts, myself and a group of Lexingtonians made up of faith-based leaders, city council members, state and city legislators, representatives from grassroots organizations, community-based nonprofits, representatives from the public school system, business and finance, academic medicine, and others have been meeting on a weekly phone call to discuss community needs, to problem solve and strategize, to develop methods for disseminating knowledge about COVID-19 resources and stimulus packages for individuals and small businesses, as well as to develop initiatives to address COVID-19 in our community. And Senator Reginald Thomas has been involved in this effort, and I would like for him to speak to some of the initiatives and some of the strategies that this coalition and this group has taken on at this time. You are muted, so you want to make sure, Senator, that you unmute yourself. Senator, can you hear me? Okay, so while he's getting himself together, Dr. Brown, I know your area is in the area of cardiovascular disease and hypertension risk among African Americans, and we have seen that individuals are more at risk or predisposed to COVID-19 who suffer from cardiovascular risk factors and hypertension. I'm wondering if you would be able to speak to why that is the case.
Yeah, it's a very good question. First, let me just say how happy I am to join in on this webinar. It's been great so far. Yeah, you know, the process, we're early into this COVID-19 pandemic, and data are just really starting to emerge. As I've read studies about this, it's basically unclear at this point. We are not able to establish causality between hypertension and COVID-19 infection. There are some hypotheses that are floating around, and one of them has to do with antihypertensive medication, particularly the medications that block a particular system, renin-angiotensin-aldosterone system. There's been conflicting data about whether these antihypertensive meds are beneficial or harmful.
I want to come back, huh?
And there are data, very few data, to support each one. One of the issues with hypertension, it's well known to be inflammatory state, so heightened inflammation. And inflammation is a key part of COVID-19, especially lung inflammation. So I think hypertension is similar to some of the other comorbidities, diabetes in particular, that also have heightened inflammatory states, which could exacerbate the effects of COVID-19.
Thank you, Dr. Brown.
Dr. Fernandez, can I go back to your question now?
Absolutely, yes, please.
Okay, thank you, because there is much I want to say, and I really enjoyed the discussion given by the gentleman from Louisiana in the last forum. I want to point out where we are here in Kentucky. Kentucky presently has an African-American population of only 8.5%. Thank you, Dr. Price. We're one of the southern states that had the smallest population. If you include West Virginia or not, only West Virginia has a smaller Black population than we do. Hispanic and others make up about 77.5% of the population. And Kentucky's about 84% white. So Kentucky's pretty much a white state. However, when you look at where we are in terms of COVID infections, what we've seen to date is that even though Kentucky's 8.5% of the population, we have contracted 34% of all the COVID cases in the state. That means 4 times our population is what we've contracted, compared to whites, which are, as I said, make up 84% of the state population, but have only contracted about 55% of the cases. So you can see right there the significant health disparities that exist here in the state between blacks and non-whites and whites. And so that's obviously what we've seen across the country. That is certainly true here in Kentucky. I will add on the good side, however, that of all the southern states, Kentucky is the only one that has, since the adoption of the Affordable Care Act back in 2010, has had Medicaid inspection. We were the first to do it. We remain the only state to do it. And that has certainly helped some. And to be frank, we needed it because if you look at our health statistics, we rank at the bottom or near the bottom in so many health categories: obesity, hypertension, diabetes, heart disease. We've got a lot of work here to do in Kentucky when it comes to healthcare. I strongly agree with what was said before, that it's just not talking about problems that you see in terms of having these comorbidities that aid in COVID deaths and COVID cases. It really goes back to priorities and where states spend their money. And states are no different from us, Dr. Fernandez. That is, you look at where we spend our money and you can see where our priorities. Look at where the state spends their money and you see their priorities. And what we need to do, in my opinion, and this is my recommendation in light of the forms that I've presented in the past, that we really need to push politically to have more money spent on healthcare access. That it's just not talking about it, but we need to go beyond the Affordable Care Act and talk about other political measures, other structural measures that are going to ensure that all people in this country, regardless of race or regardless of their zip code or their income status, have access to quality health care. Until that happens, until we put money behind it, we're going to continue to see these problems that impact us, impact impoverished people, and have an impact on where people live. That's what has to be done.
So as a state senator in Kentucky, you're aware that our governor recently promised that all Blacks in the state of Kentucky would be insured. And given your position in the Commonwealth's legislature, what steps are you aware of that are being taken to fulfill this promise?
Well, I am aware that Governor Beshear promised that. As you well know, Dr. Fernandez, he's a Democratic governor and just got elected last year in a state that people consider red. I don't think Kentucky's as red as people think it is, but he defeated an incumbent governor, Republican incumbent governor, in this current political environment. So I think that speaks highly in terms of where Kentuckians' minds and hearts are. However, Dr. Fernandez, again, to reiterate what I said before, that's going to take money. And right now, because of the COVID virus, not just Kentucky, but all states have been impacted seriously by loss of tax revenues, due to the economy slowing down and haven't quite picked up. So, that will take some time. What we did this past legislative session, which you are aware of, is that generally speaking, Kentucky, we are constitutionally required to have a 2-year budget. We have a biennial budget process. But because of the uncertainty that existed in our budget process, this year. We only have a 1-year budget. So we have to go back in our next legislative session in January and adopt a budget for 21-22. At that time, we'll look at where we are revenue-wise, but I support Governor Beshear. There's a lot of support here in the state, for making sure that Blacks do get full healthcare access. His father started us down that road almost 10 years ago, and so I think that will happen. But again, we got to put our money where our mouth is.
Thank you. Kind of changing course somewhat, going back to the etiology of COVID-19, Dr. Brown, there was a question that was presented around the area of alternative forms of therapy or research and treatment, including food as medicine. Can you speak to this area as it relates to the interplay of COVID-19 in individuals? You're muted.
Okay, yeah, I can speak a little bit to that. And again, I'm going to start out with saying the research is just new. I mean, people are just now conducting research, and nearly all of it is retrospective at this point. I will go back to a point I stated earlier. These drugs that block the renin-angiotensin-aldosterone system, there has been a little bit of data that has shown that they also may help reduce the symptoms of COVID-19. Again, very small sample sizes. There's a whole lot to do. With my lab, I'm a big believer in non-pharmacological forms of therapy, and we do experiment with them on blood vessels to try to make blood vessels of African Americans healthier, and thereby hoping to reduce high blood pressure. So I have not read of anything yet, but I can guarantee you that people are working on it, and I just have only seen some mentions of it, and that's all.
Thank you.
Yeah.
Going back to you, Senator Thomas, a question was posed. What type of messaging can communities put out into their communities? How can they do that in concerted ways to really target and tailor messaging to marginalized communities and communities that have been adversely impacted by COVID-19? You're muted. You need to unmute yourself. Yes. There you go.
I am so glad you asked that question, because as we near the end of these 4 forums, that allows me to make this very important point. The best messaging, Dr. Fernando, we can give comes on November 3rd of this year when we vote. Okay, every action or decision that we want to make that's going to advance this issue of creating equalization of healthcare access, eliminating, as the gentleman said, not disparities, but inequities. I like his distinction. It comes down to voting for people, Dr. Fernando, who are going to do what we want them to do. Okay, so my answer to your question and to all the forum members is that we have to encourage everyone we know, cousins, brothers and sisters, family members, to get out and vote to address this topic we're talking about today. That's the best message we can give. You, Dr. Fernando, and others you know, have to go out and vote on this November 3rd so we can make the changes that we aspire to make and desire to make throughout this forum today.
And as we have done in our coalition, Senator, you know that we have really emphasized voting for our communities and try to really stress that within our group, our community coalition. So I think that is critically important, as you say. Another question that was presented was how to teach high school anatomy and physiology, and to build a curriculum of health equity into courses for high school students. Could either of you, what Dr. Brown first, maybe then you could speak, Senator, on that topic? You're muted.
I'm sorry about that. Yeah, I can be really quick. I love that question. It is imperative that we embed this information in our curriculum as early as possible, because, you know, from what I see, and I know all of you do too, there's just a lot of misinformation, as well as just some ignorance about what this is. As was mentioned earlier, the first reports were that Blacks could not get this disease, right? And so if we had health information in an equitable way from the very beginning, we would be able to make knowledgeable decisions about these kinds of health issues that pop up. And then you're not relying on misinformation on social media, things like that.
Senator Thomas, would you like to comment on that?
Well, as you know, Dr. Fernando, I'm never at a loss for words. And first of all, I want to say I agree with Dr. Brown, and I also like his choice of baseball teams. I think it's baseball cap in the back, and I too am a devoted and longtime Cubs fan. So we have that in common. As you know, Dr. Fernando, in the city of Lexington, where you and I both live, the mayor has recently formed a commission on racial and social justice to look at all aspects of racial inequality and structural racism here in Lexington. One of the issues, and I've been talking to some young people about this, one of the things I'm going to do is have young people come and speak to that commission. And Dr. Fernando, in our K through 12 education system, we have to start allowing these young people when they get to high school and train them up, even in the 6th, 7th, 8th grade, to look at areas that they might want to take on as a profession when they get to college. Now, that's not true for everybody, because a lot of people go to college and not know what they want to do. And I will also quickly add to your question that college is not for everyone. But if you have a student that wants to go to medicine, so going back to Dr. Brown, then why don't we have that 10th, 11th, and 12th grader, have a course in which they practice or intern at the University of Kentucky Medical School, or at St. Joseph's Hospital, or at Baptist One. I think we need to do more of that. We need to do more of that, in high school, is have these students intern, and it doesn't have to be just in medicine. They could do medicine, they could do architecture, they could do engineering, they could do law. I'm a lawyer. But I think we need to give these students some practical experience in addition to just teaching them, algebra, English, and biology. Because a lot of students just come out of high school and they don't know anything. They don't have any idea what is their inspiration, what really turns them on. And I think that's one of the things that I want to present to the commission as we look at, how we can eliminate, structural racism is to give all students some practical experience, while they're in high school. I'm a big believer in that.
So speaking to what you just said, Senator, I have started a Black Boys and Men in Medicine program. It's a mentorship pipeline program that extends from kindergarten through residency to expose young African-American males to professions in healthcare. So we will be talking further about that.
Why don't you invite me to a meeting, Dr. Fernando?
You are invited. I will be talking with you a little later offline. Dr. Brown and Senator, I want to thank you. I'm going to turn it back over to Dr. Feast-Price to close us out with this segment.
Yes, I'd like to say thank you to our distinguished panel Thank you, Dr. Fernanda, for wonderful questions, providing a great overview of what's happening here in the state of Kentucky. Dr. Brown, thank you very much. Very informative. And Senator Thomas, exceptional information. You've emphasized the importance of voting. All things happen when we vote. I'd like to turn things over to Drs. Churchwell and Dr. Taylor to close us out.
Well, Dr. Churchwell.
Yes, I'm trying to get my video going here. Here we go. All right. Hey, Christine. Great.
Hey, how are you?
Boy, what a superb set of lectures and information exchange. Very rich, very diverse, based on where you live. The conversations are somewhat similar, but very different.
Absolutely. Give us a lot of food for thought. And I think things that we can think about. I was struck by some of the key messages that I heard. One was that of structural issues, that COVID-19 exists within a structure that we're aware of that goes back for African Americans more than 400 years, and that we cannot begin to solve this totally without acknowledging that historical infrastructure in which it exists. That was a very powerful takeaway for me.
Yeah, I think one of the things that was mentioned by Dr. Tyndall, I'd like Consuelo to weigh back in if she's still on the call with us, and maybe others who are involved in education. We have a situation where in medical school, as in college, as he pointed out, University of Florida, it is a great opportunity and an important opportunity for those students, either medical students or college students who have an interest in public policy or public health, to get really engaged. And what this has required is many of our schools have had to pivot and create courses that didn't exist before. We have created a course here called the COVID pandemic course. And we had a lot of time to create courses when we sent everybody home. We had time to sit and reflect, but it's what the students demanded. They wanted to know how this would impact, this was something that they didn't get in their regular medical curriculum or their college curriculum. And so we actually had to pivot and create those courses. Dr. Tyndall, do you want to mention that again? Do you have any connection with that vis-a-vis University of Florida Medical School? How did they have to pivot to it in terms of course structure?
Absolutely. So first of all, I'll just say that I've got my screen the right way now. Apparently, the background was sort of a mirror image, so I now have a chance to redeem myself. Here's what I would say, though. The COVID experience for us, obviously, when medical education essentially was shut down, really presented several opportunities. It presented an opportunity for students to actually further engage in community in a manner in which they hadn't before. It created what I think of what Byron Stevenson says very famously, created proximity, a kind of proximity or being proximate in a way that really hadn't happened before. And I think it was really an appealing opportunity for students to volunteer that way. But we actually instituted courses and curriculum specific to COVID. And it is really very interesting because as we began to see the issues of inequities become more and more exposed, that obviously changed the timbre and the types of discussions that actually occurred within that curriculum. So it was actually interesting to see how that actually evolved over time. So, I say this, whether it is the COVID related issues, which was very obvious, or some of the other issues that are tearing at our social fabric, we have to use these as extraordinarily important opportunities to do better, to better educate our students, and to really, I think, achieve something that perhaps today we've not been able to achieve, because those students of all backgrounds are going to be our future workforce, and they better be more educated than perhaps we may have been to tackle these issues, to be much more enlightened, and to be able to make impactful change.
Yeah, that is spectacular. And I think Dr. Wilkins is leading the charge at Vanderbilt, because as we deal with COVID, you pivot right into racism, right? The social fabric issues that have been really pushed and destroyed. Consuelo, you want to comment on that?
Yeah, just quickly, I wanted to say that we certainly have seen this real, uprising, I would say, from the students and and their desire to make sure that their education is really grounded and rooted in health inequities. And there was a pandemic medicine course that was quickly stood up at Vanderbilt in the medical school. And one of the tracks was focused on health inequities and vulnerable populations. And so I'm just flashing those objectives there. Our track was, there was high demand, including that even after all the students were assigned, they had to rank these. We had students who came back because they didn't get their first choice, which was our track, asking if they could be involved and how they could be involved. And we really did focus on making sure that they could think about this from the policy level. They compared some of the policies around whether or not in certain communities, people with specific backgrounds and whether or not you had your immigrant status prevented you from getting access to some of the resources. And so they really did go beyond that traditional, biological, physiological space into looking at some of the social determinants of health.
Dr. Churchwell, I would also like to add that here at the University of Kentucky, I have been teaching a course called Race, Racism, and Health Disparities for over 10 years to medical students as well as students in the health sciences across the university. So for folks who are thinking about developing curriculum around race, racism, health inequities, I'd be happy to share some of the things that I share and teach in class and provide some resources for those who are interested.
Dr. Churchwell, I was just going to add, I'm at UAB School of Medicine. I teach a special topics course. It's just a 1-week intensive course. As some of the other med schools, they've done a good job with bringing in COVID-19 sort of public health courses. But the students, again, the students have led the charge to have a much more around health equity and cultural competency. And that has been more of a challenge. I think that the administration agrees with it, but where to put it and how to structure it has been a struggle. So that continues to be a struggle, but the students are actually demanding it. And the talks have just begun.
Dr. Churchwell, I'm wondering if someone on the panel could speak to this issue of messaging. As communication is my area in focus, I was really struck by how important the accuracy, the quality, and the source credibility of the messenger has to be in this process. And perhaps there are some panelists who've spoken about that could share ideas with the rest of us.
I can address that. Being in the media, we've done a lot of focus groups recently to discuss how people will relate to the message that is actually coming out. And what we find is that you would even think that the more scientifically based information would kind of go over the heads of some of the more, less educated African Americans or minority populations. And what we found is that as long as the wording and the verbiage is not at the medical school level, people still want to hear the science behind what's going on, because they know that so much of this is politicized right now that they don't know what to believe. So the trusted face, which I hate to say, sports figures, famous people, those have resonated the most. But people that are not necessarily in medicine and people that are not necessarily in science, but giving the scientific method or the message in a way that they understand. So I'll give you an example. So we did this program called Use Your Head, Stop the Spread. And we talked about, we had like one of those videos to show if a certain person doesn't have on a mask and they go into a restaurant, what would it look like when they talk? So you saw all the particles coming out of the person's mouth, and then we put the mask on, and then the particles they were a little blocked, right? So that was it was visual, but we had someone that discussed it who was kind of a local celebrity. And that resonated with all the focus groups much better than anything else, just because I think that people want to know the truth. They just don't know what the truth is. So truth has 3 components. It has to be the message, the messenger, and the path and the track record of the platform. So we know some of these things on Twitter right now or Facebook may be a little bit sketchy. So, you know, it has to be the platform, the message, and the messenger have to be congruent, and it can't be shucking and jiving. I'm a straightforward guy. It's not that shucking and jiving and pandering, you know, because it seems like it will work. That's the kind of things that pharma companies come up with when you have a diversity panel and you have one Black person on a diversity panel and that Black person has never dealt with Black people, but just because they're Black, you say, okay, well, that dude, he'll let us know what to do. That doesn't work. So you have to have real community members that know what they need to know. Just because they speak loud doesn't mean that they're the most.
Agreed. We're privileged to have actually the person who gave us the idea, the Chief Diversity Officer gave us the idea to do this, has joined us. Derek Rivaris, Chief Diversity Officer at LSU. He doesn't have the purple LSU behind him, but he had a question to share with us. And Derek, please, you've got the floor to share a question.
Yeah, and I'll take the advantage of the floor and thank both my colleagues, Dr. Taylor and Dr. Churchwell, for leading and shepherding this moment, and certainly the folks at Vandy for putting this together. And I'll also give a shout out to my boy Corey, because I was driving down the street the other day and his voice comes over the radio with the same message that he just got through sharing with you. It works. It absolutely works. And Senator Thomas, this is my team. I think you're absolutely right about voting. We've got to vote. We've got to vote like our lives depend on it, because they absolutely do. My question to the panel is simply this. We've been, and you guys have presented a ton of great information. I think we talked about the students getting a richer curriculum and embracing the diversity and the inequities. But I'm concerned about the practicing physicians that are out there mistreating patients based upon some old deep-seated thoughts about the patient's race, their gender, their sexual orientation, a whole lot of factors. And they're making medical decisions based upon these factors. What can we do to help educate those folks, or if we get real radical, to remove them from practicing?
I'm going to go around the horn and have Corey go, Consuelo, and then Dr. Janger, but I want to kind of add to that question, which is a great question, Corey, which I was actually going to add. We had someone mention early that we had the issue of Blacks don't get COVID. Now, we heard that generations ago, Michael, didn't we, when we heard Blacks don't get cardiovascular disease?
Right.
Back in up until 1985, it was believed Blacks died of suicide or other conditions and didn't realize we had the same kind of heart attack rates, or more so, in our women and men than whites, until Reagan's people came along, oddly enough. So this keeps coming up, what Blacks don't get. Can you speak to that, Corey, in the context of what Derek was saying, and then we'll go around the horn there.
Yes, I will tell you, I have a presentation that I give on race and equity, and there's a concept that's a paper that was put out, and I put my other computer up. It's a concept paper that talks about whiteness and health. And when I tell you, it's a very deep paper, because white people tend to think that their whiteness allows them to encroach on our Blackness as far as health. And when I say that, it's no crack on anybody at all. It's just the reality of and I'm gonna take it one step further. Just think about how many times a Black person had a Black teacher from kindergarten through 12th grade. And then think about how many times you had a Black male teacher from kindergarten to 12th grade. Not many times. So when does a white person at any point have a Black person have a Black person tell them unequivocally that something that they're doing is wrong? Think about that concept. If you have never had someone Black tell you that A plus B is equal to C, and you did A plus D is equal to C, then you, no matter what your grade level, you will never feel at any point that Black person has some type of dominion or equality to you at all. So I mean, it gets to a really interesting point. I'll send that study so that they can be disseminated throughout the group.
Great, thank you, Corey. Consuelo?
I think just quickly, and I know a lot of people are already familiar with this iceberg where, above the surface, you see covert things like police brutality and KKK hoods and those sorts of things. And then just beneath that is the unconscious and implicit bias. But really at the foundation of that, iceberg or pyramid or whatever structure you're looking at are those systems that are in place that we've just accepted on a daily basis. And when we start to challenge them, people sometimes get offended, and it's so deeply entrenched, even when things like, when we say, what is race? Some physicians sort of think they know what it is, but they don't really know what it is. They can't define it. And when I say, how do you measure one drop of Black blood? And how does that make you Black? I expect the quantitative sciences to be able to tell me how to measure one drop of Black blood, but you can't. And so I think unlearning a lot of this is also a challenge, and we've got to really dig deeper if we're going to start to dismantle some of this.
I'm gonna go to Alex and I'm gonna go to Pamela. Alex, you need to unmute. There you go.
Got it. Thank you. I think I echo what a lot of Dr. Wilkins said. For me, kind of circling a little bit back to one of the original comments, the messaging is so critical here, and whether it's messaging to the people you want to serve, or to the medical students in the next generation, or to our own colleagues, I think we have to be more vigilant so that we break through some of these barriers and these statements that have already been, that I hear some of my own colleagues make, and recognize that that's the only way. Now is the time, and hopefully we can influence the next generation, but we still have about 80% or 90% of current physicians are not the next generation. So we need to make sure we continue that and message the right way, both as mentors and as people who are treating others. So thank you.
Enough folks who believe the truth to speak up, enough herd immunity around us in our medical schools, in our classes, in our hospitals. Pamela, just briefly, we're running out of time, but I would love to hear your thoughts.
Yes, we think about our learners as current learners, but we probably need to think about our community physicians as learners as well. And so that continuing medical education is a key point that we need to think about. And we probably need to develop curriculum around this for them as well, particularly the alum who we can reach quickly, but also others who are out in the community.
Right. Well, I think we're getting close here. Christine, you want to have some wrap-up thoughts here? And I'll close it.
I think the wrap-up thoughts are that this is where social justice meets with medicine. And it's an imperative that we borrow from both of those paradigms in order to solve the challenges that face our nation, and particularly those who inhabit Black and brown bodies. I'm thankful to all the panelists and thankful to have been a part of organizing this process with you.
Well, thank you. We really appreciate everyone here for sharing and taking the time. I think we've put forth some ideas that would not have come about if we didn't have the mixture of all the different SEC regions and cities and ideas. So I think where we go from this is that we take some of the things that we've heard and we create maybe a path forward for us through the SEC, a coalition of teachers and leaders in medicine and health and public policy to address some of these things that are unique for the Southeastern region. So we hope you all have enjoyed this time. We look forward to doing this again. I thank my colleagues all around me, and thank you for tuning in. Thank you.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you, guys.